We'll start with good news. As it has been mentioned, and some of my slides are the same as you just see, so we go faster. Survival increased substantially among HIV-infected persons. As you see on the right, the percentage of viral suppression increased over the year, and now we are above 90% of viral suppression among treatment-naive patients, and new drugs are more potent than it was before. They are better tolerated, and they are simpler. And I think, I don't know, but the clinician perspective, during my medical school, we do not really learn about the cost of what we prescribe. So I think it's important to take this concept into account of cost effectiveness. So after the good news, there are the bad news, and the bad news is that the cost of treating a patient for his life is about $500,000, and as we say, 3/4 of this price comes from the treatment, the antiretroviral treatment. In this study published by Lohan by the group of Yazdan-Pana in 5 years ago, you can see here that it's 76% overall, but if you look at the highest level of CD4 cells, it's even more, and as you know, more patients as treated, as there's no threshold for starting treatment, so this proportion of cost is about to increase as we treat sooner patients. Another bad news is that it's not just treating patients. Here you have the well-known Gardner cascade, which has been described a few years ago, and you see that treating patients is just the tip of the iceberg, but we are more talking now about community-level viral load and treatment as prevention and PrEP. So all these other strategies, which has been shown to be very cost-effective, needs money also. So the standard model that we all know, if you want to buy something, for example, if you want to buy a car, you make the choice between the sophistication of the car and the money you have in your bank, and you decide which model you can buy. This is the standard model. The health economic models is much more complicated. I try to explain with little icons. So you have the society, for example, the FDA of the MEA, who make the drug approval based on phase 3 trials, and it's essentially based on efficacy and safety. This is the two main points. And the society also will pay for this innovation or new treatment. And here is the point that is the topic of my speech. It's the clinician perspective. We make the drug prescription, but we don't pay what we prescribe, hopefully. And we get no individual benefit of what we did. In contrast with the woman who buy the car and then don't have to take the bus. And and finally, the patient who get the benefit or the side effects, it depends. But it's not. We are in the middle, like a sandwich, and we are in the middle. So we didn't hear a lot about cost effectiveness in our studies, but we heard a lot about evidence-based medicine. We know that we should follow the guidelines. The guidelines are very important. And the guidelines are based on the best research evidence which requires knowledge of the concept and critical appraisal, but there's a new concept which is not evidence-based medicine, but more evidence-based practice. And of course, it's not just evidence-based, but you have also a clinical expertise, and your patient is not representative of an average patient in a study. And when you have an individual relationship with a patient, you have to be sure that the results of one study will be applicable to this particular patient. All the patients are different. So it also needs clinical expertise, and more in HIV and in medicine in general, patients' value and preference have an importance. It can be the case that you know that the treatment is better for example, surgery versus medical treatment, but the patient needs to take a part of the process because it's how it will work the best. So I will now take some example about knowledge and concepts. So as we've seen, the cost effectiveness plane, I think this is a very important graphic to understand. You have a difference in effects between a new treatment and the reference treatment. And on the y-axis, you have the cost with a difference in the costs. And when you compare two treatments, if the new treatment is more expensive and less effective, the decision is easy to take. And it's the same in this diagonal. If the new treatment is better and less costly, which is quite rare, I have to say, the decision is easy. More difficult is when the treatment costs more and is more effective. And I think there's a part of this diagram which is not very well understood. Maybe it's a little taboo, but it's when it's less effective but less expensive. We don't like to talk too much about this point, and I will come later with the use of generics. So once you have this cost effectiveness plan, you calculate the incremental cost effectiveness ratio, and you have the willingness to pay, as we've just seen. And here, for example, all the points will be below this line will be cost effective, and above this line it won't be cost effective, even if it's more effective. And as we just say, it's difficult because the p-value for statistical testing is 0.05, and everybody knows that. For the willingness to pay, it depends a little bit of the politics, and we don't really know which is the best threshold. So I took an example about one study which compared Atripla versus Genvoya or Stribild. It's a very famous study conducted by Paul Sachs and Andrew Cheng from Gilead, and has been published in The Lancet in 2012. It was a randomized, as you see, a randomized control trial, a phase 3 for drug approval, and they demonstrated based on standard endpoints the percentage of patients with a viral load below 50 copy at 48 weeks, that the two regimens were quite similar. So they demonstrated the non-inferiority. In terms of resistance, you see that 2% in each group had a resistant failure. So it was, I don't know if the right word is non-inferior, but at least similar. And in terms of tolerance, if we look at the treatment discontinuation due to side effects, it was also very similar, 4% versus 5%, but very non-inferior, okay? And the conclusion of the Lancet paper, because this study was done before approval, because it was used for approval, they say that this regimen would be the only single tablet once daily with an integrase inhibitor regimen. So this was the phase 3 trial. And subsequently, there was a cost-effectiveness comparison between the two drugs. So because it costs money to develop a new formulation, if you compare the old drug with the new drug is more expensive. So we are in this part of the cost-effectiveness plan at the northeast of this graph. So what the authors found, I'm not sure that you read this journal every day, such as Lancet, but I did it for you. You see, you are here with the evaluation, with all the parameters, because you have viral load, and they translate this into QALYs, which a lot of formulation, which except the author, nobody can replicate with the same results. And then I don't know if you see it very well. They conducted a resample bootstrap with the distribution of all the variables, and you see the probability of having an ICER above 100,000 is only 27%, to say that the new treatment is cost effective. And if you put the willingness to pay, a lower willingness to pay to 50,000 euro, it's even less likely to be cost effective. So you see, you have the efficacy and safety trials, and it doesn't mean that it's cost effective. One problem with this exercise to model the cost effectiveness is the estimation of the parameters, which comes from a randomized double-blind phase 3 trial, which are not necessarily representative of the estimates you will have in clinical practice. You see, for example, the rates of CNS symptoms in the ATRIPLA was less than 2%, as a clinician have the impression that it's lower than we could see in real life, because patients are selected to participate in randomized trials. So this is maybe the most, I think, the most important paper in cost effectiveness in HIV. Or maybe some of you already read it. It was done by Walensky and published in Annals of Internal Medicine about the generics in the US. So they compared, I said they compared 3 regimens. You have the ATRIPLA, which was the reference at the time of the study, and they had 2 pills with 1 generic and 1 branded treatment, and 3 pills with 2 generics and 1 branded treatment. And what they've done, they assessed the efficacy of ART, and in their paper, I don't know if you remember this paper, they chose the reference group was no treatment. They compared to the absence of treatment, which is not really the standard of care in general. But I think the idea was that it was to avoid the compartment of the southwest, which means less effective and less expensive. So you see, because you see the branded treatment had the highest in their estimate, the highest percentage of viral control, and the more you use generics, and it's not just generic because they also switch emtricitabine by lamivudine, and some say the half-life is longer, and emtricitabine may prevent resistance. And what they assessed the costs, and what they found is that the branded treatment had a cost-effectiveness ratio above $100,000 as compared to the 3-pill generic-based regimen. You see, compared to no ART. but you have to read this graph as an incremental. So it's the reference group is 3 pills when you consider branded art. So this was a very shocking paper. When there was an editorial, and it really had the potential to move the frontiers. So one question is, it's 3 pills against a single tablet regimen. Does the adherence to treatment impact cost effectiveness? So I took the example of PrEP. You know, PrEP is very effective when it's taken, and as many drugs. And this is a presentation from my friend David Banksberg at the CROI. And you see in different studies, you have here the percentage of patients with detectable tenofovir levels. And of course, the lower the tenofovir detected, the lower the HIV protection. And you see the magnitude of the difference in efficacy. That's terrible. And it's difficult to predict. It depends on the population you treat and what you do to make the treatment accepted. And on your left, I put a very complicated model done by the group of Sood, recently published in Clinical Infectious Disease. I won't go into the details because I couldn't do it, but it's transition models with with a lot of hypotheses about the rate of transition. And the objective of this paper was to assess the cost effectiveness of PrEP among HIV in Los Angeles. But the conclusion of the paper, despite these very sophisticated models, was that the success of this strategy depends on acceptance of ART and PrEP adherence. So you see, how can we predict, and this is important to take into account when assessing a cost-effectiveness analysis, is the adherence to the drug, and it's difficult to modelize, and it depends on the population you will apply this intervention. Regarding the pill burden, our group demonstrated that a lower pill burden, this is a meta-analysis of randomized controlled trials, and you see on the left that the percentage of adherence decrease as the number of pill increases. It's significant, and the percentage of viral suppression also decrease when the number of pills increase. So the Wamsley study comparing 1 versus 3 pills may be biased by the fact that in real life, and this is from randomized trial, in real life this phenomenon may be more important. So one other question is, as I mentioned for the 3-build versus a 3+ study, is when you estimate parameters, you take into account efficacy, the cost of the side effects. And here you have the Wamsley study published in the New England, comparing dolutegravir and efavirenz, and you see the percentage of discontinuation of the drug in this study was 2%, 10 patients out of 400 patients, and this was in a randomized trial. And De Boer and Brickman have shown that on those Kaplan-Meier curves in clinical practice, I guess, but these rates, you see if you put at 40, these are days, and this is the percentage on dolutegravir, and these Kaplan-Meier curves are stratified without abacavir or with abacavir, and you see that it's more than 10% without abacavir that stop at 48 weeks, and even twice more with abacavir. So you see 2% in clinical practice versus 20% in randomized trial and 20% in clinical practice. So this contributes to the difficulty, I think, to have an idea of the impact of a new treatment in clinical practice. And I think sensitivity analysis cannot take into account so large uncertainty. So when we assess QALYs, we also need to give a value on attributes, and it's important. Our group evaluated the patient preference in France and the satisfaction about their treatment. And I just put this slide to show you an example of the methods. It's called Discrete Choice Experiment, DCE, and we ask patients about those two scenarios, which one they prefer, and we change the scenarios, and so that we can isolate the importance of each characteristic. Is it the size of the pills? Is it the speed of the decrease of the viral load? And I think it's not published in the New England Journal of Medicine, but I think it's important to ask patients what they prefer, and it's a field of research which might be more investigated in the future, I hope. C'est bon. Okay, and I think it's one of my last slides. Papo and Yazdan Pana very recently published in the famous journal AIDS a budget impact of antiretroviral therapy in Bichat Claude Bernard University Hospital. And it's a very large hospital in France. And what they saw is that based on their large cohort of patients, this was their initial treatment, and they simulated potential switch and assessed the budget impact of these drugs. Switch. And what they found is that if you use more generics, but generics is not the only answer. You can also switch protease inhibitors treated patients who are on first or second line and with virological control to simpler therapies. And if you do that, you will save a lot of money. And I invite you to read this fantastic paper. So in conclusion, we've seen that the scientific literature is difficult to assess for medical doctors in the field of economy. The parameters included in the model may be uncertain because there's a difference between randomized trials and clinical practice. And prescribers need to select the patients more likely to respond to intervention. I think the physicians have to ask themselves this question about saving costs for the good of others. And I think this is why medicine is more an art than a science. And I would advise to target switch to generics and switch from protease-boosted inhibitors to simpler regimen, eventually with an NRTI or B-therapy. But we need more expertise and more basic data on this topic. Thank you for your attention.